Okay, so thank you again for uh, providing me this opportunity to share some of the work that I do. As I mentioned in my introduction, I do work in cancer policy and global oncology. And cancer groundshot is a philosophy that we introduced almost 5 years ago now, when there was all this talk about cancer moonshot projects going on in US about innovation and finding new molecules and finding new drugs to treat our way out of cancer care. I do a lot of work on global oncology, global health, and so I realized that it's not just the new drugs and new innovations that we need, but we also need to be able to make sure that whatever we have discovered to be meaningful for our patients should reach the patients. Otherwise, there is not much point. So we introduced this philosophy called cancer groundset. It's basically the idea about how we prioritize our decisions in oncology. I call here global oncology, but I think the principle is valid no matter where we are practicing. Uh, so just to give you some background, this is a relatively new drug that has recently been approved for metastatic breast cancer, HER2 positive breast cancer. It's called margetuximab. It's a new drug in advanced metastatic HER2 positive breast cancer. And if you look at the results, these are the results. And if you look at how much benefit patients are getting from this drug, if you look at the median PFS rates, median PFS time, it's 4.9 months without this new agent and 5.8 months with this new agent. So you can see that the difference is less than a month here. It's 0.9 months. It's like nothing, but it is statistically significant. The p-value is less than 0.05, but the difference is so small. And, I had written paper about this, about why this drug is not meaningful, and so on. And if you're interested, you can read this paper. But the point that I'm trying to highlight here is, at least in West or in the so-called high-income countries, we have the privilege of debating whether or not this drug is important for our patients, or whether or not we should fund for this drug as a community, whether or not we should spend our resources for this drug that improves not survival, but progression-free survival, which means delays progression that we see in the scan by less than a month. And it costs almost $15,000 a month. But that's a privilege that we are able to have such discussion about this new drug that has lots of side effects, does absolutely nothing for survival, delays scan growth by less than a month. And I think that's a privilege because we don't have to worry about whether or not these patients are getting surgery, or whether or not their pathology is correct, or whether or not they're able to get radiation. We can debate about these newer drugs. The control arm, as you can see here, is trastuzumab. Now, trastuzumab is a very important drug for HER2 positive breast cancer. It's a really wonderful drug. But the reality is, almost 90% of the patients in low-income countries who have HER2 positive breast cancer, they don't have access to trastuzumab, not this new drug, but trastuzumab. So, that's a contrast that I want to draw, that it's a privilege to be able to debate these issues when the reality globally, if you look at it, is like this. If we look for surgery, then by 2030, annually, 45 million cancer surgical procedures will be required, of which 17.3 million cancer patients will need surgery, and 10 million of those will be from low-income countries. However, less than 25% of these patients will be able to receive safe, affordable, or timely surgery. Less than 25% of them will be able to get surgery. Surgery is not delaying progression by a month. Surgery can make a difference between cure versus no cure. It can be a difference between life and death, but less than 25% of the patients will be able to receive that. When I make this argument, some people argue that, oh, but it's expensive to build surgical facilities. It takes a lot of manpower to train the manpower, to build the infrastructure. So we cannot afford to invest in cancer surgery. But the reality is, we cannot afford not to invest in cancer surgery, because by 2030 alone, we would be losing almost 6.2 trillion US dollars due to lack of cancer surgery. So the argument is false. In fact, we cannot afford not to invest in cancer surgery. The situation with radiotherapy is no better. Radiotherapy, again, makes a big difference for curing cancer. It's, again, not a question of delaying progression by a month, as it is with drugs that I showed earlier. But even in case of radiotherapy, more than 50% of the patients requiring radiotherapy in LMICs, they lack access to this treatment. And if we look at low-income countries alone, more than 90% of the patients who need radiotherapy do not get radiation. In fact, there was this very eye-opening article published in BBC in 2017 that really caught my eye. And the title is very provocative. It says, do US dogs have better access to radiotherapy than Nigerian people? And the data shows that for every 1.3 million cats and dogs in the US, there is one radiotherapy machine. But for almost 47 million people in Nigeria, there is only one radiotherapy machine. So the equation is quite different. Again, it's nothing against cats and dogs. We all love them, but it's about the inequity in distribution of resources for cancer care across the world. In that context, when the cancer moonshot was announced by Joe Biden when he was vice president at the time in 2016, highlighting precision medicine, data sharing, genetic screening. So those were the pillars of cancer moonshot program, how we are going to focus on immunotherapy, precision medicine, and this genomics data to come up with newer cancer treatments and innovations for our patients, which is important. Don't get me wrong. We need newer innovations. Our patients are still dying from advanced cancers of all sorts, and we need treatment, new treatments as soon as possible. But there is a concern that we are focusing too much on these cancer moonshots and newer innovations, that we have forgotten that for a cancer intervention to improve outcomes, it actually has to reach the patients. There is no point in having an intervention that does not reach patients. And the problem here is all of us, when many people are focusing on cancer moonshots, the other aspects, they get ignored. So in fact, like there are almost 10 different cancer moonshot programs going on in the US alone with billions of dollars in it, and people are not focusing on the implementation aspect of it. And it's not just a craze in high-income countries. It is also applicable for low and middle-income countries. I wanted to show this contrast together. One article says surviving cancer in a country with no radiotherapy machine, and shows how people are dying due to lack of radiation. And in the other one, you see a study from India, which is also a low and middle income country, but the study is about Watson for oncology and how it is useful for making treatment recommendations in LMICs. Watson for oncology is artificial intelligence based software that is supposedly as good as a medical oncologist to give recommendations based on the patient's history and pathology data that you enter into the system. But this was at first trial in MD Anderson, and it actually failed. And like in the US, several cancer centers, they have gotten out of Watson for oncology now. But they did this study in India. And the conclusion of this study was like, okay, in India, Watson for oncology can be helpful to make these treatment recommendations. But I thought this was such a huge contrast in that we, on one hand, we don't have even radiotherapy machines in several places, but we are thinking that artificial intelligence is going to solve our problem of inequity in access to care. So I wrote this paper in Lancet Oncology saying, does global oncology need artificial intelligence? And my conclusion was that we need a natural common sense more than any artificial intelligence to effectively control cancer in across the world. I'll show you a graph. This is a graph of cervical cancer mortality rate. The redder the country is, the higher is the cancer mortality rates. And as you can see, most of the red regions of the world are in low-income countries in Africa, in Southeast Asia, and some parts of South America. Now, this graph is actually heartbreaking because cervical cancer is one rare cancer where we can actually talk about elimination. We cannot talk about elimination for any other cancers, but for cervical cancer, we can. We have HPV vaccinations, and we have effective cervical cancer screening modalities, and we have effective treatments for early detected cancers. So in fact, there are certain high-income countries like Australia and New Zealand that are on course to eliminate this disease. So it's a cancer that can even be eliminated if you can implement all these strategies early on and effectively. But several countries in the world exist where cervical cancer is the #1 cause of cancer-related deaths among women. So this shows the contrast between, how to set our priorities, how to set our focus. Now, in order to solve this problem of cervical cancer, it's not that we are lacking new drugs, and new drugs are not going to make this graph look any better. We need to invest in HPV vaccination, cervical cancer screening, and effective treatment of early detected cervical cancers. Immunotherapy and precision medicine is not going to make this graph look any better. And that's when we wrote about cancer Groundshot in Lancet, in which we we propose that a parallel cancer Groundshot is needed. By parallel, we mean parallel to cancer moonshot, to improve the lives of patients with cancer today and in the next 2 decades. This strategy would focus on the implementation of treatments that are already known to work, incentivizing research on affordable and cost-effective interventions for cancer control, and strategies that can be applied globally to reduce cancer morbidity and mortality. And actually, it's a matter of satisfaction that cancer Groundshot has now become mainstream in the oncology world. And in fact, in last year ASCO, they had a separate session on cancer Groundshot, which I had chaired, and where we spoke about several issues related to cancer Groundshot and global oncology. But at least cancer Groundshot has become now a mainstream topic. However, there is still a huge difference in funding that goes to cancer moonshot initiatives versus any cancer Groundshot projects get. Again, if you are interested to know in more detail about cancer Groundshot, we had written this book chapter for the ASCO educational book, which I can share later by email, in which we outline our philosophy of cancer Groundshot in detail. So related to cancer Groundshot is the concept of financial toxicity. Now, financial toxicity is a relatively newer term in oncology literature. We talk about physical toxicities of cancer treatment whenever we are recommending any new therapy. We talk about side effects like nausea, vomiting, alopecia, diarrhea, whatever bad things can happen. But financial toxicity is something that we don't talk often. Financial toxicity is all the detrimental consequences that can happen because of the extra expenditure related to cancer treatment. And unlike the physical toxicity, the financial toxicity affects not only the person, but also the family and the society at large, even healthcare systems. So in this paper, we try to define financial toxicity because there was no official definition for financial toxicity until that point. And when we're talking about cancer Groundshot, the importance of cancer Groundshot is that, it also considers not only the outcomes in terms of survival and progression, but also in terms of overall quality of life, of which financial toxicity becomes an important point. And to show you, some idea about how big of a problem financial toxicity is and how it affects patients and patients' quality of life. If we look at the causes for financial toxicity can be caused from 3 different sources. One is increase in expenses, the other is reduction in income, and the other is losing health insurance or having increased premiums for health insurance costs. Increased expenses is obvious. People will need to pay for the cost of cancer drugs if it's not fully funded, and they'll also need to pay for services and supportive care if it's not fully funded. This problem becomes more severe in systems where there is no public health insurance, and especially for cost of cancer drugs, even in Ontario, for patients who are between the age of 18 and 65, whose oral medications are not covered by OHIP, it always becomes a challenge. And then there is the cost of transportation and lodging, and little cost like parking and and food on those days. They all add up. And then there is reduced income because people have to take days off of work. There is loss of employment, and even if people are working, there is reduced efficiency at work. And sometimes the family or the caregiver also needs to take time off from their work to support the people. And then there is the issue of health insurance premiums rising or even losing health insurance in some cases. To give you an example of a study that we did in Nepal, we looked at financial toxicity in Nepalese patients with acute leukemia. Now, to give you an idea, acute leukemia is a disease that can be controlled with old drugs. And this is, in most cases, a curable disease or at least a long-term survival. And the drugs that we use are very old cytotoxic drugs that have been there for several years, and all of them are generic. It's not brand name drugs. But even for these patients whom we are treating for a short course with these old cytotoxic drugs, we found that patients in Nepal, they had meaningful financial toxicity for this treatment. 94% of our patients had to ask money for charity from the public. 88% of them were borrowing loans at a very high interest rate from friends or relatives. And 87% of them, they had to sell their property. They were selling their house, land, or livestock to support treatment. 73% of these patients had to do all three of that, which we defined as extreme financial toxicity. And if this is the case with acute leukemia, where we use cheap old drugs, we can only imagine what is the case with other solid tumors where we are using all these newer therapies. But having said that, when we think about cancer care in LMICs, but also in high-income countries, it's not just the lack of access that we need to be focusing on. Lack of access is an important issue, but there is also a simultaneous issue of overtreatment going on, which we cannot ignore. Because most of our new therapies, they are what we call pseudo-innovation. Although they claim it to be innovation, they are pseudo-innovation. I'm showing you a picture of two molecules here. These two molecules, they look almost the same, but they are two different drugs. And both these drugs are used in liver cancer, hepatocellular cancer. And one drug is supposed to be used after the patient has already failed on the other drug, when in fact these drugs are just me toos of each other. The only difference, if you couldn't notice, is this fluoride atom here. So one of these drugs is regorafenib and the other is sorafenib. They, for all intents and purposes, are the same drug, but they are supposed to represent innovation in oncology. And you would not be surprised to find that this drug regorafenib, it improves survival against placebo, not against sorafenib, against placebo by less than 3 months. It's almost 2.5 months. And so we keep celebrating these newer Me Too drugs that represent false innovation and forget to implement the innovations that actually work. So we wrote this paper in Nature about how do we share the priorities, especially for low and middle income countries in terms of clinical trials. And obviously, there is no point in LMICs participating in clinical trials of this type of new drugs that do not represent true innovation. But what are the type of clinical trials that the LMICs should focus on? How can we improve the clinical trial participation across the world and also make it meaningful? And we identify several areas that can be of mutual interest between high-income countries and low-income countries. And these will represent the areas for co-development where the two countries can work together. So, this is not the type of innovation or the trial that we need. To give you an example of how far we have fallen in terms of ethics of running clinical trials. So this is a trial of a drug called cemiplimab for patients with non-small cell lung cancer with PD-L1 of at least 50%. This trial enrolled patients between 2017 and 2020, 710 patients from 24 different countries. And this trial led to approval of this drug in the US. However, the problem is that For these patients with PD-L1 of at least 50% non-small cell lung cancer, pembrolizumab was approved as the standard of care because it substantially improved survival way before this trial started enrollment. That means if patients were not a part of this trial and if access was not an issue, the patients would have received pembrolizumab in routine care. But in this trial, half of the patients, they got chemotherapy. We already knew that chemotherapy was inferior to pembrolizumab. So this is a trial of a new immunotherapy called cemiplimab, but the control arm is chemo. We already know that chemo is going to do worse. And these patients would not have received chemo. They would have received immunotherapy if they were not a part of the trial. So a basic ethical principle of clinical trial that patients should not be harmed as a result of participation, that has been violated. And on top of that, they use this trial to get the drug approved in US, but this drug still remains unapproved in other different countries where this trial was run. And in fact, this is a big issue in global oncology that we try to highlight time and again, and we are asking for several reforms. If you look at, there was a very interesting study where they looked at these trials that are run outside of US, but lead to approval of the drug in the US. And they look at how up to 5 years after the approval of the drug in the US, whether these countries that participated in the trial, whether they had access to that drug or not. And if you look at, for example, Africa here, up to 5 years, the percentage is 0. That means African countries participated in clinical trials of these drugs, and that drug got approved in the US, but 5 years even after that approval, 0% of these drugs were available in Africa. So that is what in global health we refer to as research parasitism. That means we are just, research parasitism. That means we are just using patients from low-income countries to run a clinical trial that would not have been approved or legal in high-income countries to just get the drug approved back in high-income countries. Again, if you want to read about this in detail, we have written it in a paper that I have cited here. So what type of innovation do we need? We definitely don't want such type of pseudo innovations, but we definitely need what we call frugal innovation. I don't know whether you are aware of this term or not. Frugal innovation means innovations that are low cost and therefore can be used easily across the world. So just to give an example, this is not for cancer alone, but just to give an example, if you know about the foldscope, which is a paper-based microscope. So that's a great idea, a great example for frugal innovation. We may not be able to buy microscope, but foldscope is a pretty cheap alternative. And over here you can see using sari. Sari is a cloth used by women in the Indian subcontinent to filter water, and that has been shown to reduce the incidence of cholera. Cholera used to be a big problem in the Indian subcontinent. And of course, there is no availability of filter everywhere in low and middle income countries, but they showed that if you use a simple sari cloth to filter water, that in itself can reduce the incidence of cholera substantially. And similarly, the use of plastic bottles as asthma spacers, because those asthma spacers are expensive, so you could simply use plastic bottles as asthma spacers. So similar frugal innovation is what we need in oncology as well. And just to give you an example from COVID-19, in COVID-19, we have two drugs that have shown some benefit. And let's just compare these two. One is remdesivir, the other is dexamethasone. In remdesivir, mortality benefit was marginal, but for one course, it cost more than $3,100 US. And this drug was not available globally. It's not even now available globally. And compare that to dexamethasone. Mortality benefit was substantial. It's cheap and affordable, and it has been available globally for several years now. So this dexamethasone type trials is what we need. And there have been some examples of such trials in oncology compared to these newer innovations and newer molecules. There have been several examples of trials from India and China and other countries testing the cheaper drugs and cheaper combinations as opposed to the expensive alternatives. And something to say about locally developed Me Too drugs. We talked about Me Too drugs and how they represent pseudo innovation, but sometimes in the local context, Me Too drugs can make sense. For example, Here is an example of a trial of a drug called aumolertinib. Now, this is in lung cancer. There is a new drug called osimertinib, which is pretty expensive. But in China, they developed their own Me Too version of osimertinib called aumolertinib. And they did this trial and saw that aumolertinib was effective and it was better and mostly comparable with the osimertinib. And they get this drug at a substantial discount in China. And they wanted to propose those same drugs in the US market as well, but the FDA rejected it, saying that the drug was tested only in China. It did that for sintilimab, the other immunotherapy as well. But, if for the local context, for the Chinese population and for other LMICs who cannot afford osimertinib, they will very well be solved by getting access to aumolertinib, which is a much cheaper version of that. And in fact, there is some data to show that when a new Me Too drug enters the market at a cheaper price, it leads to competition and it leads to lowering of prices of other existing drugs as well. You don't see this in US and Canada and other high-income countries, because when a new Me Too drug is launched, it is usually launched at the same or even a higher price than what we currently have. But in low-income countries where they manufacture their own local Me Too drugs, they launch it at a lower price, and that competition will lead to lowering of the prices of the existing drugs as well. And we're talking about the role of clinical trials in low and middle income countries. Something to say about the non-inferiority trials, because in many of these trials, the problem is that the patients in the control arm, they are not getting good treatment. And we are also trying to test for low and middle income countries, not only the newer innovations, but also the de-escalation strategies. Can we do less and achieve better outcomes or equivalent outcomes? So in those cases, I think testing for non-inferiority between the existing treatment and a lower dose or a shorter duration or a lower frequency of the treatment might be a good idea. Just to give an example, for example, in prostate cancer, abiraterone is a drug that used to be given at 1,000 milligrams daily. What they tested was, can we give, instead of 1,000 milligrams, can we give 1/4 of the dose, 250 milligrams, but we give it with fatty meal, and fatty meal increases the absorption of the drug. And they found that you could actually give 250 milligrams with fatty meal and have similar outcomes. So that there is good cost saving right there. Instead of giving 1,000 milligrams, we're giving 250 milligrams, 1/4 of the dose, 1/4 of the cost, and having similar outcomes simply by giving it with fatty meal. With immunotherapy as well, we used to give high dose of immunotherapy, but there was an Indian trial in head and neck cancer where they tested a very small dose, because for immunotherapy, there are reasons to believe that the outcomes do not necessarily depend on the dose. And they found that giving just 20 milligrams of nivolumab would improve outcomes in head and neck cancer. So yeah, patients may not have the capacity to afford the full dose, but they might be able to afford this low dose. And similar is the case with shorter duration treatments. For example, trastuzumab in the adjuvant setting, it used to be given for 12 months. We still give it for 12 months here, but there are several trials that show that we can give it for 6 months and have some benefit. One trial showed that you could give it only for 9 weeks, just 3 doses, and derive similar benefit. And also about lower frequency, zoledronic acid, for example, it used to be given every 3 weeks, and newer trials for that you could give it every 3 months instead of every 3 weeks and have similar outcomes. So these are the type of trials that we should promote and invest more in addition to all the new moonshot type trials. And when COVID-19 happened, actually, it was an important opportunity for us to think about low value practices. During COVID-19, we deprioritized several practices because we thought they were not in patients' best interest during the time of pandemic. But we need to go a step further and think, if those were the services that we thought were not important during the time of pandemic, are they important even when there is no pandemic? Are they practices that we have just been doing because we have been doing that for several years without thinking deeply about it? And if it is something that we did not do during the pandemic, we need to carefully consider, is it important enough that we need to do it again now that the pandemic is over? So in summary, Cancer Groundshot is simply about priority setting, what interventions we want to invest in, what interventions we want to test. If we're talking about clinical trials, what are the type of clinical trials that we want to invest in? It's not a replacement for Cancer Moonshot. Cancer Moonshot and newer innovations are important, but we should not forget that the innovations that can't reach people are meaningless. You have a wonderful new drug, but it will not save any patients if the patients cannot take them. It does not reach the patients. There is no point. So ensuring implementation of high-value proven cancer treatments is equally, if not more important than discovery of newer interventions. And sometimes less can be more. And it is in the best interest of patients as well as the health systems to test such de-escalation of therapies. And many lives are lost, not because they did not have access to the newest technology or newest drugs, but because they did not receive proven treatments in time. I did not show you data from high-income countries here. I showed you mostly data from low-income countries, but this is true no matter where we see. Like even in Canada, there are pockets of population that have such poor access to treatment that their outcomes are worse than the outcomes of patients that we see in low and middle income countries. So that's something that we need to keep in mind. Thank you.